Old age is 50 years older than I am. And that's, Bernard Baruch was a financier and statesman back in the early 1900s. For those of you from New York, Baruch College is named after him. And he lived till 95, so I think he had a lot to know about being old. But why is prescribing for older adults different than younger adults or children? A few main factors. One is pharmacokinetics, and Dr. Bruno had alluded to pharmacokinetics as it relates to Parkinson's disease drugs. Pharmacokinetics, oftentimes referred to as what the body does to the drug, so things like absorption, distribution, clearance, those are all factors that change as we age, things like clearance and renal function, for instance, so that's one factor. The other one relates to pharmacodynamics, and that's the effect of the drug on the body, concentration at the receptors where they work, the affinity at the receptors. So this relates to not only the efficacy of medications, but also can relate to adverse effects. And then lastly, drug-drug interactions. We know that as you get older, the higher chance that you're going to be on multiple medications, and so you have to be very mindful of drug-drug interactions. Any talk at a geriatrics conference, they'll take away your geriatric card if you don't mention the Beers list. How many of you have heard the Beers list before? Yep. So the American Geriatric Society, about every 3 years, comes up with a list of potentially inappropriate medications for use in older adults. They emphasize this is potentially inappropriate. It doesn't mean that you can't use them or that they're contraindicated, but it's medications to be careful about. Since this is a talk about antibiotics, I should mention that there are a couple of antibiotics on the list, namely nitrofurantoin. The main concern with that, two things. One is it's a concern, or it's potentially inappropriate if you have impaired renal function, particularly a creatinine clearance less than 30. And it's not meant for long-term use because of the risk of pulmonary fibrosis and even hepatotoxicity. So those are the caveats, but nitrofurantoin's on the list, as is trimethoprim sulfa. And that's really a concern if someone is also on an ACE inhibitor or an ARB because of the risk for hyperkalemia. Now, interestingly, fluoroquinolone antibiotics are not on the list, and we'll talk a bit about fluoroquinolones later. I'm not sure why, but with fluoroquinolones, there are certain serious infections for which there's really no effective or no good alternative, so maybe that's why. Or who knows, it's possible that in the next iteration, a few years from now, there may be on the list. All right. Now, most of us have the privilege of prescribing here, but with great prescribing powers come great responsibility. So this is a reference, this is Uncle Ben from Spider-Man, so if you saw the Spider-Man movie, that comes from that. But why is it that prescribing, especially antibiotics, comes with great responsibility? Or a big part of that is the problem of antimicrobial resistance. It's a major public health threat. They estimate that about close to 3 million resistant infections occur in the U.S. every year and can be responsible for about 35,000 deaths annually in the U.S. Globally, this is a much bigger concern. Globally, some of the estimates say 5 million, up to 5 million deaths may be related to resistant infections. And so really a big part of this burden is in the developing world, where oftentimes antibiotics are available over the counter without a prescription, so you can get them anywhere. The other problem is that we don't have anything in the pipeline to get us out of trouble if we have a bacteria that is resistant to all the antibiotics that we have. And so here the WHO says that they warn that there's not enough antibiotics in the pipeline to combat urgent health threats. These screen captures and things, these are actually all things that came up just within the past month while I was working on this presentation. So it wasn't uncommon. I'd see something on my phone and say, oh, that's pretty good for my talk. I better take that. So this is all recent stuff, right? And then before we get to some cases, just some general principles about antibiotic prescribing. First of all, you want to have the narrowest spectrum possible because you want to avoid collateral damage. You only want to treat kill the bacteria that you're trying to target, not the extra stuff. Everyone knows more and more about the gut microbiome and all sorts of microbiome related issues, and that's another one of those evolving fields that's fascinating. When I was in school, we didn't talk about the microbiome. So again, you want to really try to target the bacteria, the bad bacteria, and preserve the good ones. and you want to reduce the risk of developing resistant bacteria. The shortest duration possible is also preferred. It can be 3 days for actually it can be 1 day for urinary tract infections, which we'll discuss later, but 5 to 7 days for pneumonia. When I was in medical school 30 years ago, it seems like everyone was on antibiotics for 10 to 14 days, but a lot's changed since then. And then, as we mentioned earlier, there's, as one ages, it's common to be on more and more medications for different medical conditions, and so you have an increased risk of drug interactions, but that's also something that you have to really take into account when prescribing antibiotics for anyone, but particularly for older adults. So we're going to go to some cases. The first case, it's a 67-year-old man with hypertension and type 2 diabetes, well controlled. He presents to your office with 5 days of productive cough and 2 days of low-grade fever and chills. He's got a temperature of, bless you, 100.2, blood pressure 107/75, a heart rate of 88, respiratory rate of 20, and an oxygen saturation of 93% on room air. On exam, he's got some slight crackles left more than right, the bases, and you have the ability to get an x-ray where you are, and not only that, but you get a quick x-ray reading, and it says early opacity at left base. So, this is a 67-year-old gentleman with hypertension and diabetes who presents with the community-acquired pneumonia. So I'm going to ask you, which is the best antibiotic for this man with community-acquired pneumonia? You've got 4 choices: amoxicillin clavulanate, moxifloxacin or Avalox, amoxicillin clavulanate with azithromycin, or cefpodoxime Vantin. So let's do a show of hands. How about who votes for the first one, amoxicillin clavulanate? Got some. How about moxifloxacin or Avalox? Okay. Amoxicillin clavulanate plus azithromycin. Good. And then cefpodoxime Vantin. Excellent. Okay. So before we get to the best answer for this guy, we'll touch on the bacterial causes of community-acquired pneumonia. It's classically broken down into typical and atypical, but typical includes strep pneumo, which is the most common. So actually many times there's never an organism identified, first of all. But in the cases that are where an organism, specifically a bacterium, is identified, strep pneumo is the most common, up to 30% depending on the studies. But this is changing significantly in older adults because of pneumococcal vaccination. Haemophilus and staph and then gram-negative organisms are much less common. And then there's what we call the atypical bacteria. They're called atypical bacteria because they don't stain on gram stains like the regular traditional bacteria, and they're beta-lactam resistant. So these are what we're talking about, like Legionella, chlamydia, and mycoplasma, which are usually more of a factor in younger adults. All right, so when we talk about the first-line treatment of community-acquired pneumonia, we can look to guidelines by the Infectious Diseases Society of America, IDSA, and the American Thoracic Society, ATS. And in 2019, they updated their guidelines. And they say for outpatients without comorbidities, so typically these are younger adults, the 3 antibiotics that they recommend as first-line would be amoxicillin, doxycycline, or a macrolide, like azithromycin, if pneumococcal resistance in your community is less than 25%. I actually honestly don't know what the pneumococcal resistance rate is in Honolulu, so I don't know how many of you know in your community. But this, we're actually talking about adults without comorbidities, okay? So if you go to the IDSA and ATS guidelines about community-acquired pneumonia for adults with comorbidities, the choices are amoxicillin clavulanate plus a macrolide or doxycycline. So you get the typical and the atypical coverage. A third-generation cephalosporin, such as cefpodoxime, but again, plus a macrolide or doxycycline. Or if they cannot take either of the above, then a respiratory fluoroquinolone, such as moxifloxacin or levofloxacin.